Welcome to AETCM, the Emergency Medicine Channel. Today, I'll be presenting a case of a 3-year-old male child who was brought to ER with complaints of fever, cough, followed by 8 episodes of GTCS in a gap of 5 to 10 minutes. PAT assessment, appearance-wise, child was spontaneously moving minimally in mother's arms and was irritable with a non-consolable cry, with no interactions or gaze. That was the PAT appearance. And breathing wise, there was no any increased work of breathing or respiratory distress. Circulation wise, color was normal, no pallor, mottling or sinuses was seen. Primary survey, airway was patent, no stridor or gurgling of sounds or pooling of secretions. Breathing wise, air entry was bilaterally equal, saturation of 99% of room air, respiratory rate of 36 per minute. Circulation wise, heart rate was 136 per minute, BP of 90 to 60 millimeters of mercury. Disability wise, he was AVPU score, if you check, it was around painful only response is interacting with us. So and also he was irritable, and pupils are equal and reacting to light. GRBS checked that time was 94 mg per deciliter. Exposure wise, temperature was 100.2 degree Fahrenheit. Weight of the baby was 12 kgs, and we had given he came around 180 kgs. So PCM paracetamol 15 mg per kg, suppository was initially given 170 mg. And secondary survey, patient is a 3-year-old male child who had complaints of fever with worsening of cough since on the day of presentation. He had history of cough for the past 1 week, and he was on Asthalin and Budicort nebulizations. Around 1 p.m. on the day of presentation, he had around 6 episodes of tonic-clonic movements of all limbs with the drooling of saliva and uprolling of eyes, and it was there in a gap of 5 to 10 minutes without regaining any consciousness, and each lasted for around 1 to 2 minutes. And he was taken to nearby hospital, where he was given initially midazolam nasal spray, 2 puffs was given, and after that it again resolved, but after that again recurred. So they gave another injection, lorazepam, 1 mg IV stat was given, and he was referred here for further management. And also he gives there was also history of sleep disturbance was present, and there was no history of any drug default, and no history of any focal neural deficits also, and allergic, no history of any allergies to any medication. Medication wise, the patient is on valproate 200/300, Levipil 250/375 mg, lacosamide of 50 mg/50 mg, frisium or clobazam 2.55. So that is the regular medications he was taking. And past history, his he had an uneventful antenatal and perinatal histories, and onset of seizure was from 3 months onwards. That time they had evaluated and diagnosed with Dravet syndrome. Dravet syndrome is basically autosomal dominant type of condition, which is also known as myoclonic epilepsy of infancy. So it's more like a drug resistant kind of genetic epilepsy syndrome. So there is actually that sodium channel defect is there. So there is, due to the loss of function, the inhibitory neurons, the sodium channels, when it gets activated, usually inhibits the impulses. But since that sodium channel is defective because of the loss of function mutation, that sodium entry won't happen, and inhibitory neurons won't act. So there will be rapid firing of neurons. And so in these cases and all, that sodium channel anti-epileptics with sodium channel blocking action should be avoided, because it can aggravate the situation. So if this patient had autosomal dominant type of Dravet syndrome, and last EEG was done on May last year, and it was showing a left centrotemporal epileptic activity with a slowing. That time MRI brain done was normal. And last food intake was yesterday, like the day before yesterday, the presentation, previous day night 8 p.m. And on examination wise, right now patient was conscious, irritable, pupils are equal and reacting to light, no obvious facial asymmetry was present, and no focal neurology deficits as such were present. Other examinations were within normal limit.
Okay, so this case scenario is not very unique that we see, because what we see in one aspect of seizure disorder in children, febrile seizure being the most common one that we have discussed. So this scenario being already a known case of rather than going a seizure disorder, it's a proven case of Dravet syndrome. On top of that, the child have developed a febrile illness, and which has precipitated the seizure.
Seizures,
so it's not very common to see such events happening. But anytime when you think about a seizure child, if they are going for fever episodes, definitely they can have seizure disorder. So here we will be focusing not on febrile seizures. So we had discussions on febrile seizures before. We have discussed what is complex febrile seizures, what is simple febrile seizures, and all those things. Here we'll just concentrate on a pediatric seizure other than non-febrile conditions. What are the conditions that we need to understand, and how will we tackle them in the emergency room? So that is the major idea. Can you know any other syndrome similar to Dravet syndrome?
Lennox-Gastaut is also another
Then
refractory syndrome.
Refractory seizures, West syndrome. Have you heard of West syndrome?
West syndrome.
These are all West syndrome is a little bit more common as compared to this Dravet and all. We had seen few more cases since being our center has got an exclusive pediatric neuro. We used to see a lot of these sort of cases in here. So the key aspect when the child comes in, we have to divide their age group, and depending upon their age group, we can categorize what are the possible causes of seizure. So that is how we need to approach a seizing child in the emergency room, apart from febrile seizures. So the most common reason being a febrile seizures, and any pediatric age group, approximately 5% of them will have a seizure episode before 16 years of age. So that is a general incidence of seizure in pediatrics. So, and again, if the parents are at high risk, definitely the risk of having seizure for the child is also very high. So that is the general aspect. Now let's see, how will you approach a seizing child? How will you categorize them? For example, they have come in the neonatal age group. So in the neonatal age group, what are the potential causes that you need to anticipate when child develops seizures?
Hypoglycemia.
Okay, hypoglycemia.
Dyselectrolytemia. Hypocalcemia.
I will put hypoxia, hypoglycemia. Hypoxic encephalopathy will be the most common thing that we will be seeing. Yeah, hypoglycemia, obviously, yes. Any other electrolyte abnormalities, and maybe later down inborn errors of metabolism and genetic causes and sepsis related neonatal sepsis and all those things you can see. But the most common high index of suspicion, hypoglycemia and hypoxia. These things should be striking in your mind when you are seeing these age group, neonatal age group coming to us with seizure. Then just proceed. We have converted from the neonatal age group till 6 to 6 months of time. What will be the most common presentation of seizure during that age group? 6 months. 6 months. 6 months, that's the time usually this sort of seizure disorder or storage disorders. Again, glycogen storage disorders will present with seizure. So that is the next category of patients that you need to remember. From 6 months of age till you have like 18 months or you have like 3 years of age, where the most common reasons will be an febrile seizure followed by meningitis, meningoencephalitis, all those things. Definitely all other reasons, seizure disorder can also precipitate during that age group also. So that is the usual spectrum of how the different causes that you need to think over when a child presents with seizure. So now the important thing, what are the specific things that you need to examine in the child? You have said regarding the PAT assessment, resuscitation. I am not going into that aspect. I am just saying that this child is stable or otherwise who had a seizure and come to you. So what are the specific things for a seizing child in the ER that we need to look in for our examination findings?
Examination findings. In examination wise, we'll have to, if it's a first time presenting to us, we don't know any background history, we have to see for any dysmorphic features related to the any genetic conditions.
Okay, dysmorphic features.
We have to see for any neurocutaneous markers.
Very important, neurocutaneous marker. Which all the neuro?
Shagreen patches or
Cephalo spots, the most common one. Neurofibromatosis, cephalo spots. Then
spots,
port wine,
ash leaf macules,
port wine, Struger-Weber syndrome. So these are the common things that we need to look in for. So first, examination of the skin and the face that you have said. Then
we have to see for any focal neurological deficits.
Okay.
Any weakness, any involuntary movements, myoclonic movements have to be seen. And fontanelle, bulging fontanelle, meningeal signs.
Meningeal signs onto the neck, meningeal signs. Then
we have to see
anything in the abdomen, hepatosplenomegaly. Glycogen storage disorder, I have said. Hepatosplenomegaly you need to look in for. And also another important thing we need to developmental assessment has to be done. And another important thing what we need to differentiate is between whether it's a real seizure or is it a pseudo seizure or it's a seizure mimic. So what are the different seizure mimics that you know of?
Seizure mimics, we're coming to the differential diagnosis as such. Then we have
common one you tell first.
Breath holding spells is most common. So in breath holding spells, it usually presents from 6 months to 18 months usually, but can present from neonate to 5 years also. But most common present is 6 to 18 months. Patient will always have a precipitating factor. And whereas in epilepsy, there will be mostly an unprovoked seizure episode.
And aura.
Aura will be present.
But in that age group, we will not be able to elicit that aura.
That precipitating factor, emotional aspects will be, or any pain will be inflicted to the child. So initially there will be a crying episode, and at the end of expiration there will be a complete apneic episode.
Okay.
And patient on examination also we might be able to see two types of breath holding spells, a pallor type and cyanotic type. So either a pale or a cyanotic child will be able to examine, and also it will recover after. Sometimes there won't be any post-ictal phase
Confusion.
as such.
It will be a lasting brief small smells, not like seizure where you technically speak any seizure should subside within 5 minutes, but breath holding spell will be less than a minute. It will not be prolonging more than that, and they don't have any post-ictal confusion. And what will be the other differentiating bowel and bladder incontinence? Usually breath holding spells not seen, but definitely yes in this thing. Focal deficit, as you said, it's more in favor of seizure. And again, if it's a focal activity, more in favor of seizures. So more in favor of a seizure. If it's a generalized activity, that is and flickering of the eye, staring look, these are all more in favor towards a seizure. Okay, then breath holding spell. The next one,
syncope. Most common seen is syncope, which is actually a very transient loss of consciousness with loss of postural tone due to the reduced cerebral perfusion, and there will be rapid recovery from that situation. So there won't be any as such any tonic-clonic movements or any seizure activity as such won't be visualized, and there won't be any post-ictal confusion as such. Patient will recover at a faster pace. So that will be mostly seen in syncope. And urine incontinence can
be seen in
both. And that can be due to other causes also have to be ruled out in syncope, like cardiac arrhythmias, vasovagal syncope conditions have to be ruled out. And then we have the third one is we have a BRUI. BRUI is actually brief, resolved, unexplained event. So in the name itself it is there. So it is brief. It is over a shorter period of time, and it will resolve on its own without any intervention, and it will be, the cause won't be apparent. So if we evaluate the patient also, there won't be any unexplained cause for the event. So that is BRUE. So but you have to rule out the other causes.
Okay.
Then we have hyperekplexia. Hyperekplexia is basically a genetic condition. So it is actually also called a stiff baby syndrome or startle disease. So in that the patient during wakefulness it will be present, but epilepsy will be present mostly in sleep also. So in wakefulness patient will have full stiffening of the body, and startle reflex also will be exaggerated. And they can have myoclonic movements can be present, and that also can interfere with breathing and cause cyanosis. And then other one is as we said, pseudo seizures
in children, especially in teenage age group. Specifically, they start visualizing something, they start seeing the films, movies and all, so they will start understanding there is something called a pseudo seizures.
So it is also called as PNES, which is a psychogenic non-epileptic seizures, which is not related to any epilepsy. So the patient can have associated features of anxiety and like hyperventilation, and they might present a seizure with a closed eye state. And also they can vocalize also in between the seizures also, they might vocalize. There won't be complete loss of consciousness.
And another thing, they will have cycling movements. In children specifically, they will be doing the cycling movements, thinking that is how the seizure activity needed to be recreated. So that is the main thing. And eyes closed. Seizure with eyes closed. So that will be the classical thing that you need to remember regarding pseudo seizures.
And tonic features won't be present, only clonic movements.
And you cannot have sometimes a fixed pattern. You will have sometimes right lower limb, right upper limb, or it might be a generalized. But the post-ictal confusion, the bowel and bladder incontinence and all those things you won't be able to see. Usually in the teenage age group you can suspect during the pseudo seizures. Okay. So that is the usual differential diagnosis that we need to keep in your mind. Then coming to the investigations, what we need to do. So now the investigation, you have made a proper possible diagnosis of seizure. What will be the key investigations that you need? Definitely what all blood investigations that routinely we do, focusing upon the infection parameters, meningoencephalitis and all those things, electrolyte abnormalities, all those things we will do. So, blood investigation I am not going to discuss much, but coming to the imaging aspects, who all needs an imaging?
So, imaging requirements, we can say it as based on emergent MRI, emergent imaging requirement or non-urgent requirements. So, if it's an emergent requirements, usually patients with acute head traumas, or patient having a fever episode with other meningeal signs, or a patient is having underlying malignancy to rule out any tumors, or if the patient is having any underlying any anticoagulant or having any bleeding tendencies,
disorders,
bleeding
sickle
disorders.
cell diseases, or you are having a patient with ITP, or he's taking for AML, CML AML, not CML, AML treatment, then definitely you need to do. Then focal
Focal
deficits.
deficits, new onset or post-ictal focal neurological deficits that is not resolving in few hours. So if it is persisting, then we'll have to rule out any structural lesions and papillodemas or having raised
Papilledema or
ICP
retinal
features.
hemorrhages.
Retinal hemorrhage.
Retinal hemorrhages and papilledema, definitely you need to. Then
Persistent headaches.
focal seizures.
Focal seizures are important.
If the focal seizures,
Seizures will always be associated with usually a structural lesion and abnormal EEG findings or any epilepsy syndromes might be present.
so that these are the key things that you need to know. Emergent imaging is required for these group of patients. So remember, it's simple. It is not that complicated. When you are suspecting a meningoencephalitis, and you are suspecting any stroke or bleed, you need to definitely, depending upon what the patient is pressing, any signs of raised ACP. If you are getting any other signs of raised ACP, we have already discussed, like vomiting, persistent vomiting, papilledema, and all those things. You need to go ahead and bulging of the AF. You need to go ahead and do the brain imaging. CSF analysis.
And usually in pediatric, they prefer MRI because reduced radiation exposures, and also we won't get certain findings in CT like any migration defects in pediatric age groups or any mesial temporal sclerosis and all won't be seen.
Non-traumatic. We are saying about non-traumatic condition. Traumatic, definitely CT is the gold standard. Okay, non-traumatic.
So if the patient is stable, we can further proceed with the MRI and all. But if there is instability, then we can do a quick CT.
Okay, CSF analysis.
CSF analysis usually in the same case. Usually in infants, we'll have to do less than 12 months presenting fever, meningeal signs, persistent altered sensoriums,
not taken vaccine,
having an immunocompromised status, have not taken vaccines, or any immunocompromised status patient, we have to do a CSF study after ruling out any raised ICP features, any papilledema and isochoria. We have to rule out and then only proceed with LP, or we have to proceed, do a neuroimaging prior to the LP if you are suspecting a raised ICP features.
Okay, now since we have discussed regarding all the investigation, now let's EEG. Who all require an EEG in the ER?
If you are not sure if it's a true seizure or a seizure mimic, we can confirm the seizure with EEG.
Okay.
There's an active seizure.
Mostly absent seizures.
And also, non-convulsive status epilepticus also we can rule out, or any subtle convulsive episodes we are not sure about seizure, then we can rule out with EEGs.
And always
also, for later stages and all, we can see what seizure type is it, or is it
what medications, how response to medication and all, we can look into
syndromes we can diagnose.
Okay.
And adjust the dose of infusions also in status epilepticus.
Okay. Now the question will be, can you let me know toxicological causes in pediatrics, whether the toxicological causes anything that we need to think about seizures? So always keep that in your mind. The presentation of various toxicological poisons. We don't know which all poison they can present with seizures. So remember that whenever you are not getting any cause, definitely you need to keep a background check whether any of the common toxicological poisons, even if technically not described to cause seizures, they can present with seizure. So you have to keep that in your mind. So there are classical, which one can produce seizure. Can you tell me one drug that can produce seizure? Antibiotic, okay. Paracetamol with liver failure, to last failure. Any other drug? Anything? Antidepressant, okay. Opioids, seizure.
Antipsychotics.
Organophosphorus.
Okay.
They can have seizure. They can have then. Because we don't know what the child has consumed. Suddenly it can be an accidental ingestion and the child is presenting you with seizure. So you have to keep that as one of the differential diagnosis. If you are not getting any reason why the child is developing seizure, always keep, are we dealing with the toxicological cause? So that's a rare thing, but just have a differential in your mind. And investigations will depend upon, you need to send a toxic sample, you need to gastric aspirate and all those things. But definitely you should have a differential diagnosis in the mind. Not for this child what I am saying, but routinely when you don't get a cause for seizure, you need to attribute whether it's any of the toxicological causes that is causing the seizure. Okay. Now let's go into the management. Usually we do the management and then we'll start the discussion. But here it is a little bit different. We'll just thought of discussing the things. Now let's see how you will be managing. ABCD, don't tell me. I'm not interested in ABCD. Definitive management, you go ahead and tell. What are the drugs that you wanted to start? and how will you plan your drug management. And definitely RSI will be the last thing. So which all drugs that you want to give for RSI, you can tell me.
So initially the management starts before hospital itself. So we have to always counsel if a patient had come with a seizure. Initially, you have to counsel the bystanders if you are not starting on any anti-seizure medications regarding the emergency management. So that left lateral position, recovery position has to be maintained to prevent any aspiration. Then we'll have to give bystanders any midazolam nasal sprays to be used in case of an emergency, or in clinic basis also it should be made available. Any midazolam nasal sprays or any suppository, like rectal suppository of diazepam.
Diazepam should be made available.
Or any IM injections at least we can give. Lorazepam or midazolams can be given. So usual dosage of midazolam nasal sprays we give is one spray gives around 5 mg. 0.5 mg. 0.5 mg. So for every 5 kgs we can give one puff. So usual dose is around 0.2 mg per kg per dose. So maximum we can give around 10 mgs. So that much dose we can usually give. And if you are giving as a Midas buccal is also available. So buccal
not preferred during seizure because chance of aspiration everything will be more. Nasal spray is ideal or suppository.
Or rectal diazepam we can give 0.5 mg per kg per dose we can give. And if that fails, then if you are reaching a hospital setup, we are able to place IV cannula, or we can give us IM route also. So we have available first line agents as lorazepam. Lorazepam is 0.1 mg per kg per dose. And if we are giving midas also, we can give from 0.15 to 0.2 mg per kg per dose. Or if you are giving diazepam, it will be 0.2 to 0.3 mg per kg per dose. So this we can give us IM route also if we are not able to secure a cannula. That will be the first line agent, and we'll again reassess the patient. There is an ongoing seizure episode ongoing. Then we'll have to roll out any other raised ICP features and all. We'll have to start other supportive managements also.
ABCD done. Okay. We have done. Just anti-epileptics.
Then second line management, we have the drugs phenytoin. Phenytoin usual dosage we start is 20 mg per kg loading dose, and then we will give it 1 mg per kg per minute as a maintenance infusion dose. And if we are giving as a phosphenitoin, we'll give it as phenytoin equivalent doses. So it will be again same dose, 20 mg phenytoin equivalents per kg, and we'll give it 3 mg per kg per minute. So in phosphenitoin we have to monitor, cardiac monitoring has to be done because the patient can go into bradycardia, heart blocks, arrhythmias.
What is the other advantage of phosphenitoin or phenytoin? You said regarding one thing is arrhythmia, and much faster we can give, action, and we can give IM also. That is the other advantage. So you are given benzodiazepine, 1 or 2 doses, still you don't get an IV access. Technically we can do an IO, but you don't have anything available. Don't you have phosphenitoin available? You can even give IM. Phosphenitoin can be given.
Okay, so then after that, if it again doesn't work, then we have other options like sodium valproate. Sodium valproate usually 20 to 40 mg per kg loading we can give, or we can give safer option which is liver safe, not toxicity in liver, or like in inborn errors of metabolism and all. For those patients, preferred choice is levetiracetam. Levetiracetam dosage usually from 20 to 60, up to 60 we can give.
Even when there are now centers, there are a lot of algorithm. They don't skip the second part, phenytoin and phosphenitoin. They will directly go into levetiracetam because more safer. As you said in the case of Dravidian syndrome, Dravid syndrome, when giving a phenytoin, phosphenitoin can be a challenging thing. Because we don't know. Yeah, it is a sodium channel blocking agent. So we don't know whether there is any underlying. Again, when we are suspecting in toxicology and whether you have consumed something like a sodium channel blocker associated, again giving that can be a problem. So many of the centers, they have made a pattern like benzodiazepine, they are straight away going into levetiracetam and followed by valproate and all other newer agents.
And levetiracetam we can give from 20 to 60 mg per kg loading dose, and we give it at a rate of 5 mg per kg per minute. And then after that maintenance dose and all we start after 12 hours, 8 to 12 hours. Then if that also fails, then we have the third line agents, which are usually general anesthetic agents. So we have midazolam. If you are giving, we'll give initial the bolus 0.15 to 0.2 mg per kg IV bolus, and then we'll start on infusion. So whenever in these cases and all, when you're starting infusions, we'll have to make sure we attach an EEG also, and secure ET tube and protect the airway, because there will be respiratory depression and airway compromise. So we'll have to secure the airway, and also we'll have to do a continuous EEG monitor and adjust the dose of the infusions accordingly. So we'll start with 1 microgram per kg per minute, and every 5 to 10 minutes we'll reassess, and based on the burst suppression in EEGs or any visualized any seizure activity, based on that we'll increase the dose by 1 microgram per kg per minute, and maximum up to we can give 30 microgram per kg per minute. And then after that, once we are having a seizure free period, that is around, we take it for one day, around 24 hours. So if there is a 24-hour seizure free period, then we can plan on tapering the doses. We taper around every 3 hours, we can taper by that same 1 microgram per kg per minute. That is for midazolam. Then another one we use is phenobarbital itself. We can use as high dose phenobarbital. So after giving the loading 5 to 10 or 20 mg per kg bolus we will give. Then after that we can give up to maximum. We can repeat every 30 minutes up to 120 mg per kg dose we can give. And that also we can target that seizure control and burst suppressions. And other one commonly used in ER is propofol. So propofol dosage is 1 to 2 mg per kg IV bolus, and then we'll continue per hour infusion of 1 to 2 mg per kg, same 1 to 2 mg per kg, and the maximum dose we can give is 5 mg per kg per hour.
In one condition, you will not give propofol for pediatric seizure. So that history I will ask before starting propofol.
Allergies to egg allergy.
That is okay. That is for everyone we'll ask. Specific to pediatrics, ketogenic diet. If the child is on a ketogenic diet, we'll prefer to avoid propofol. So that is one thing that you need to remember. So propofol, already storage disorder, ketogenic diet, the child is all, you are getting a clue. Okay, we should not be giving propofol for that child. So that is one thing that we will try to avoid. Okay.
And then other one after propofol is thiopentone. Thiopentone penta 5. So 5 mg per kg we can give as bolus, followed by 5 mg per kg per hour infusion rate, and we can taper after that 24-hour seizure free period in thiopentone. And even we can use ketamine also in situation.
Very good agent. Ketamine says that it causes raised ICP before, but ketamine is a very good drug which can cause anti-seizure activities also.
Then we can also start on topiramate if we are having orogastric or nasogastric tube. We can start same 5 mg per kg bolus dose, and then per day 5 mg per kg per day doses we can give.
But where will be, as an emergency physician, usually when we give midazolam and we use the second line agent, usually our situation changes and we will hand over the patient. But there can be situation where there is continuous seizure activity where you will have to start in any of the infusion. So don't think that someone else will come and start these things. So as you can get a seizing child which is not subsiding, the classic is status epilepticus, where you don't have regaining of consciousness within 2 seizure episodes or activity is more than 5 minutes. You will get that. So continuous, you think that you give midazolam, it is going to stop. Majority of the time it will stop. 2 doses it will stop. You are given a loading dose also will stop. But the seizure disorder sort of these children, they are going to be a real trouble, and you need to start this infusion. So you need to have your own protocol, what you wanted to start. If you ask me the safer protocol, if you ask me, I will go for the benzodiazepine, maybe followed by a levetiracetam, maybe the second line agent, maybe valproate during that time, and or a phenobarbital or valproate, followed by either propofol or midazolam, or you can go ahead with ketamine infusion. So this thing you should have your own protocol developed, what you wanted to give, because the spectrum of cases that comes to you changes. So we have to have the safer options for the safer group of patients, because we get a lot of seizure disorder child like this syndromic child. So certain drugs should be avoided. So that part you have to be very much clear. So levetiracetam, comparatively safer drug. So that's why I didn't say phenytoin or phosphonatoin. It is nothing wrong giving in these drugs, but situation demands and the group of risk patients that coming to us is more. So that is the only reason I said levetiracetam may be a better option for us.
And then other, so that after 1 to 24 hours, if after 1 hour it's persisting, we'll say it as refractory status epilepticus, and we'll try these third line agents. If still not resolving, then we'll have to see other causes, and it will be super refractory status epilepticus after 1 day. So if there is any autoimmune encephalitis, we'll have to start on methylprednisolone, or even intravenous immunoglobulins have to be given. And if there is any infection suspicion, we'll have to do a CSF studies and start on the appropriate antibiotics as well. So and also that inborn errors of metabolism, we might have to start on a ketogenic diet also. And other refractory conditions and all, we can do a vagal nerve stimulations, or we can do a therapeutic hypothermia, or even epileptic surgeries can also be planned.
And another thing what I missed is VP shunt patients. Those who are already having a VP shunt, so that those group of patients require an early imaging. You have to see how the shunt is working, whether the shunt block is the reason for seizure. So that is the child is already on a VP shunt. Also, we need to think that you need to get an early imaging. In the initial phase, we discuss we'll go ahead with the neuroimaging. Maybe that time CT might be more than enough. I'm not saying MRI will be enough, but CT will be more than enough for those group of patients. So, what will be your nutshell thing that you wanted to tell regarding pediatric seizure apart from febrile seizures?
So first of all, we'll have to do a quick history taking and examination wise, and rule out any obvious causes for any like chronic conditions. And after that, if the patient is actively, see, we other workup investigations, airway, breathing, circulation. After stabilizing that, we'll have to send blood samples for the workup, rule out infections, electrolytes, hypoglycemias, and then further we'll have to do a imaging based on the things we have discussed, the acute presentations. Based on the presentations, we'll have to plan for MRI imaging or CT based on the stability of the patient. And then further, we'll have to plan for CSF if we are suspecting any infection or meningeal signs are present. We'll have to rule out infection by doing a CSF study, and EEG for certain patients if you are suspecting status epilepticus and all, and that patients will have to do an EEG. And then we have to
drug management.
Drug management. We have to start with initially pre-hospital management. You have to advise the parents regarding the initial emergency management. And after that, once arrival in the ER, we can start. If no lines are there, we can initially start with the nasal spray, midazolam nasal spray, and then suppositories can be diazepam suppositories can be tried. And we can try the first line agents, which are IV, lorazepam, midazolam, or diazepams. And if that doesn't work out, we should ideally start with second line levetiracetam because it is liver safe and other complications are less. And when we can try with valproate also. Lower down the list will be phenytoin and fosphenytoin. And after that, third line agents will be the general anesthetic agents. So we'll have to secure the airway and start on EEG, continuous EEG monitoring, and
depending upon that, suppression
or ketamine or propofol
can be used.
Infusions also has to be started, and roll out other causes, rare causes also has to be ruled out.
Okay, fine. Thank you.
Thank you.